people can join us. Thank you for everyone who is joining us today. My name is Catherine Dugal, and I am the Development and Engagement Specialist here at Bridge, Michigan. Today, we'll be discussing youth mental health in Michigan. And this event is a part of Bridge, Michigan's monthly lunch break series, where we discuss issues that are important to Michigan residents. If you aren't familiar with Bridge, we are a nonprofit, nonpartisan news organization, and you can read our coverage every day for free online at bridgemi.com. I want to thank our Bridge members who are here with us today and who help support our work. If you're not already a member and you'd like to become one, you can do so anytime on our website, and my colleague Amber is going to drop a link into the chat here. The schedule for today's discussion is that we'll begin with a conversation between Bridge, Michigan reporter Robin Erb and all three of our special guests, and then we're going to open the discussion to reader questions. Throughout the discussion, you can enter questions into the chat at any time. If you're calling in today, you can email your questions to us at membership@bridgemi.com. Just so you know, we are recording this discussion and we'll be posting the recording in Bridge this week. Now, time to introduce our three special guests. First, we have Tim Michelin. Tim joined the Citizens Research Council as Research Associate for Health Affairs in 2016, after working as a legislative aide in the Michigan House of Representatives, as well as lecturing at Oakland University and the University of Michigan. Tim earned master's degrees in both public health and public administration with graduate certificates in public health practice and economic development from Wayne State University. Tim is also an accomplished musician, holding positions with the Ann Arbor and Flint Symphony Orchestras and performing throughout the Great Lakes region. He received bachelor and master's of music degrees from the University of Michigan, Ann Arbor, as well as an artist diploma from the Colburn Conservancy of Music in Los Angeles. We are also joined today by Kevin Fischer, who is the Executive Director of NAMI Michigan. NAMI, the National Alliance on Mental Illness, is the nation's largest grassroots mental health organization dedicated to building better lives for the millions of Americans affected by mental illness. A retired businessman, Kevin joined NAMI as a volunteer in 2011 after his oldest son, Dominique, was diagnosed with a mental illness in late 2007 and was lost to suicide in 2010. After serving on the NAMI Michigan Board of Directors as the NAMI Walks chairperson for 2 years and as the board vice president for 2 years, Kevin accepted the role of executive director in 2014. A mental health and suicide prevention advocate, Kevin is the founder and director of the Dominique Fischer Memorial Foundation and the CEO of EverybodyVerseStigma.com, serves on the board of directors of several behavioral health organizations throughout Michigan, including Governor Whitmer's Suicide Prevention Commission, the Michigan Department of Health and Human Services Mental Health Diversion Council and Behavioral Health Advisory Council, Disability Rights Michigan Protection and Advocacy for Individuals with Mental Illness Advisory Board, and is a member of the Crisis Intervention Team International Board of Directors. We are also joined, last but not least today, by Dr. Zakia Alavi. Dr. Alavi, MD, is a diplomat of the American Board of Psychiatry and Neurology and General Psychiatry and Child and Adolescent Psychiatry. Dr. Alavi is an associate professor in the Department of Pediatrics and Human Development, College of Human Medicine, Michigan State University, for the Department of Pediatrics. Dr. Alavi is involved with developing and training pediatric residents and general pediatricians about children's mental health through a State of Michigan and HRSA-funded grant. This grant, Michigan Child Care Collaborative Connect, has outreach in most counties of Michigan and provides education and consultation to primary care providers for children and youth. Dr. Alavi has published several peer-reviewed articles ranging from polypharmacy and foster children to more recently about COVID-19 and its impact on the patients served by the community mental health systems. Currently, Dr. Alavi provides psychiatric services to children through the Community Mental Health Clinic in Jackson, Michigan. Dr. Alavi is the Chief Medical Officer for Mid-State Health Network and North Care, which are Medicaid managed care organizations, 21 counties in Lower Michigan and Michigan's Upper Peninsula, respectively. With that said, I'll now pass it over to Bridge, Michigan reporter Robin Erb.
I was just going to say good morning, but it is good afternoon now. Thanks to everybody for joining us. What a great showing. I'm thrilled to see so many faces here, and some faces and names that I recognize. We have some pretty big gaps in Michigan's mental health system, and the more people involved, the more voices we have, the more ideas, the better. So just a very quick note, I also want to thank very much the folks, the experts, the decision makers, and especially the parents who helped us with our 3-day series back in June and July. Especially for parents, but for so many people, mental health issues, managing those are they're not just a full-time job. They're sometimes 24 hours a day. Some folks, are you hearing feedback? Is anyone else hearing that? Try again. But truly what I was saying is, for so many people, this really is a 24-hour job. And for many of them, there is this relentless worry, not only for their children and their families, but sometimes for themselves. And so that's why we tackled this in June. And that's what we're going to be talking about today. Those folks are why we're here to talk not only about the problems, but really more importantly, what are the solutions? How do we move forward out of this? So I am going to drop a couple of links in the chat as we go along, not only to our series, but also to some of the reference documents. We're going to be talking about some of the proposed changes, and that'll give you some background if you want to learn more about those. So let's go straight to the questions, and we'll start with Dr. Alavi. This is certainly mental health issues. Mental health challenges are nothing new for Michigan's children, but we've seen some really big pressures here during COVID-19. That feedback again. Dr. Alavi, can you talk a little bit about what you've seen in clinic this last 18 months when it comes to some of our children?
Thank you for the question, Robin. So we've seen, as you pointed out, definitely an increase in distress, mental stress, physical stress for everybody, but especially for children and youth, because they were affected on many levels. Their parents were affected, so they were affected by extension. But then their lives were disturbed and disrupted too, the children, because of school, obviously, not being able to connect with their peers, which is developmentally the key really to development at this age, during this age group. We found a couple different interesting things. One of the things that as we talked, our colleagues and I, was that we were seeing an increase in new patients. So interestingly enough, our existing identified patients who, for instance, were already in treatment, actually for the first year or so remained rather stable, if you will, if only because they weren't coming to the clinic, they weren't coming to our attention so much. We didn't hear so much from them, let me just put it this way. Plus, because school was not in session, there wasn't a whole lot of adjustment and that school-related stress. But what was interesting was that we started seeing these new patients come in, suicide attempts, depression, severe anxiety, real distress. And it was an interesting shift from an existing patient population to a whole new group of kids who perhaps were either not identified before or maybe even weren't suffering as severely before. So definitely an increase. So that's one area. The other area, and the other one is an ongoing issue, but that I think became more acute during the pandemic, and that was the sheer lack of resources. We've been in Michigan really struggling with having adequate mental health services for children for a while. But then COVID came and everything became more acute for multiple reasons, but the inpatient beds, that situation became really, really bad. The availability of kids to be seen by psychiatric specialists, always been a problem, a bigger problem now. What has helped, because I like how you started, Robin, which is we're going to be solution focused, not just about what's wrong. So something that's really I've felt good about is, these bridge sorts of programs, these access programs. One of them I mentioned already, you mentioned when introducing me, the MC3, the Michigan Child Care Collaborative. Those kinds of things really helped because we reached out to pediatricians. We were available for consultation. So where we couldn't see the kids, they couldn't be seen by specialty mental health, we could educate and support and empower their primary care person. So that was the positive that, for me at least, really kept me going and was really important during this time.
I think in healthcare and mental health care, certainly the bright, I guess the silver lining of the pandemic is it really did make us figure out different ways to reach people. I think you're right. Tim, maybe you can take it from there. Because, as Dr. Alavi said, these issues were worsened and they brought in new people who needed help during the pandemic, but some of these problems have existed for years. Can you talk a little bit about what your report found? And I'm going to put the report in the link or in the chat too. If anyone's interested, it is a large and very well done, thorough report on some of the issues that are facing our system. So Tim, can you just, in the briefest way, tell us what we're looking at?
Yeah, absolutely. Our report saw a lot of the same things that Dr. Alavi has already mentioned, but the interesting thing is that while attention was paid to issues being, associated with COVID and, in some cases treating this like it was a new issue that came out of nowhere. When we look at the trends for the past 10, 15 years, we've seen more than a doubling in the incidence of major depressive episodes among children and adolescents. And tragically, in the same period, we've seen a really stark increase in the rate of both suicidal ideation as well as suicidal completion among adolescents and young adults, to where we're now at the point that suicide is the second leading cause of death among young persons in the United States and in Michigan, only surpassed by automobile fatalities. And I think it's worth noting that there's some ambiguity in the way death records are reported, because when you look at automobile fatalities, some of those may be suicides that are not reported as such, but also depressive disorders, attention, hyperactivity disorder, substance use disorders. Those all feed into some of those automobile fatalities among young people as well. So it's been a huge growing issue, and the countervailing side of that in terms of services is that we just don't have them. Our community mental health agencies and mental health providers in general have been under-resourced, under-reimbursed, and tend to concentrate in some of our urban areas. So when you look throughout the state, we have a good amount of providers in Ann Arbor, Washtenaw County, but much of the northern parts of the state, and particularly the Upper Peninsula, there's no child or adolescent psychiatrists at all at the most recent data that I've seen. So there's a real lack of support. And what that leads to is that when you have increased need, increased demand, there are all these barriers that people have to overcome in terms of stigma, in terms of their willingness to seek care. And then when they finally make the decision, I need help, they get hit with a bureaucratic wall where there are waiting times. Can they find a provider? Can they find reimbursement for the provider? What does transportation look like? There are all these societal barriers that get in the way. And in the worst case scenario, we have people with severe issues who end up being housed in emergency rooms. And it's this sort of Kafkaesque nightmare that the bureaucratic structures in place and the lack of resources prevent people from getting the help that they need.
I want to talk a little bit about the emergency rooms, but before we get there, that's what we were hearing when we did our examination. And Kevin, maybe you can talk about this. You can talk about emergency room and the push there. You can talk about the lack of beds. You can talk about the lack of frontline providers. And we forget about those sometimes. These are the folks who go into homes and help families, help support families. What we're really talking about here is this severe shortage of workers from your very top, master's, doctorate level psychiatrists to those frontline providers. Kevin, can you talk a little bit about how that differs around the state, not only in terms of needs, but solutions? How does this picture in the UP differ from, let's say, Grand Rapids or Detroit?
So Tim and Dr. Alavi both touched on this briefly. We know that there are more resources available south of Grand Traverse County, for example, or Saginaw, than there is north. And for example, I spent some time in 2019, just before the pandemic. I was up in Houghton, Michigan, for example, and where Michigan Tech is. And it was my first time up, and I had an opportunity to stop in on a behavioral health care organization. And they brought to my attention, they have one psychiatric doctor visit available per month up there. They said 1 day out of a month, a psychiatrist visits their community. That is appalling. It's absolutely appalling. And we've heard story after story about parents who have to drive their children from Marquette to metropolitan Detroit for care because there's, as we talked about before, yes, there's a shortage of psychiatric beds. There's certainly a shortage of behavioral health care professionals across the state, nationally, if you want to go there. But of course, again, once we get to northern part of Michigan, there's such a scarcity that it's almost non-existent. And, you know, opinions vary. I talked to a psychiatrist friend of mine recently, and we were having this discussion, and she alluded to something that Dr. Alavi said. She says, well, there's not such a shortage if primary care physicians take on a greater role in this process of evaluating and directing not just young people, but all people to the resources that they need. And unfortunately, I agree with her. I mean, that has to be part of the solution, that our primary care physicians are going to have to play a larger role in at least triaging people when we know that there are behavioral health challenges. Lastly, I'll say one of the other things that has become very clear to us, and I say this with all due respect, emergency rooms are not the best place for people to get psychiatric treatment, whether they are children or adults. They're just not suited for it. We need more crisis centers. We need more mental health crisis centers that are effectively urgent care for people who are experiencing behavioral health care disorders, rather than taking them to the ERs, because the ERs are more often than not simply not equipped.
You know, we wrote about that in that second day too, and I'll share that link. But what we're really talking about here, you know, think about an emergency room. I mean, they can be chaotic. You're dealing with car accidents and the child with an ear infection. And then you have a youth who's got suicidal ideations, and the staff isn't prepared there. I want to ask you a little more about that, Kevin. You said, having the primary care doctors take on a bigger chunk of, I don't know if that would be care or kind of triage or identifying. Maybe Dr. Alavi, could you talk a little bit about that? I mean, you're a child psychiatrist. Could primary care help out?
They certainly can, and to be honest, and I work mainly with pediatricians. It's not for lack of trying. We at Michigan State, in fact, that's the reason why I'm based by choice in the Department of Pediatrics. And, we have been working for several years now with the American Academy of Pediatrics to actually make changes and add and strengthen what's already there in terms of expertise and professional competencies related to taking care of children's mental health. And really so if you think of this lack of services or this need for children's psychiatric services, if you think of them on a spectrum, on one end of the spectrum, we have to have, our pediatrician colleagues, our primary care folks trained better and have more supports. Once they're trained, they're out practicing, they're then going to need more supports, programs like MC3, and there are others like that. But MC3 comes to mind because I work with it. That's part of what I do. And really we're present in pretty much all counties of Michigan, but not every single office. And so, we need, once you have a trained, empowered primary care practitioner, you then need these bridge sorts of access programs that support their decision-making, that support their capacity to take, to treat and to care for these people. And then we come to the actual specialty care, which would be either in a private setting, in an outpatient clinic, or through the community mental health clinic. But there are many things before you even come to the specialty mental health piece that can and should be done. And the changes in the curriculum, really the curriculum and how we're training pediatricians, in fact, how we're teaching medical students, it's nationally, it's something that we're working on.
I can see primary care doctors being interested. I am not going to pretend to speak as a primary care doctor. I haven't had a single day in med school, but I can imagine them, being concerned, wanting to help, but also saying, look, I'm already dealing with vaccines and the newest research and everything else that I have to do as a pediatrician. This seems like a lot more, a pretty big lift. But I hear what you're saying too. Having those frontlines doctors helping out, I can see that being
So
very
Robin, if I may answer,
Yes.
I just saw a question pop up, something about MC3. So it's Michigan, it stands for Michigan Child Collaborative Care. It's a grant from the state of Michigan and the feds, HRSA, and it provides psychiatric consultation to primary care physicians all over Michigan. We have a website, we have a phone number, you call somebody, we have behavioral health consultants, they are positioned really nicely in each county and they'll call you right back. And sometimes the same day we can get someone to talk to you, the provider, about whatever question you may have and help you make those decisions. Thank you.
That's so critical. One of the things that I heard so often during our research for the series was that, look, my child has a problem today. I can't wait 6 months for an appointment. I can't wait to the next time around. Having somebody there to call, having somebody at the end of the phone to get you to the right program is so critical. Let me switch gears, and I have to tell you, I've written about health for several years, and my mind was just blown when I learned this during our series, that people with insurance actually may have a tougher time accessing resources. So again, we're talking people with insurance have a tougher time sometimes accessing mental health care for their children or themselves than somebody on Medicaid, which is just, obviously opposite of what I'm used to writing about in physical health. I don't know, Kevin, maybe that's a great question for you. How is that possible?
So there are many factors, but the one that we need to remember is our community mental health system is based on Medicaid eligibility, and it is the public safety net for anyone who is experiencing behavioral health crisis and needs treatment. Insurance plans don't always provide the coverage, and I guess I'll use as an example, we're all familiar with the last year, the YouTube video of the father. I know, Robin, because I know you spoke with him, and his last name escapes me right now. But the dad, I'm sorry, go ahead.
Jay Gross, and I'm going to put that link to the story in the chat. And if you haven't seen it, you have to watch his video. What Kevin is talking about is the father who's in the emergency room parking lot. His child has been in the ER for days and he can't get help, and he has great insurance.
Yeah.
Sorry, Kevin, go ahead.
No, thank you. So Jay Gross, and when Robin and I talked about this a few months ago, I said, for me, and I don't mean to be melodramatic, you have to understand the power of that video, that a father was brought to his knees, to tears. We always think about mothers being nurturing and all of that, which is all well-deserved. You have a grown man, a father, who was reduced to crying in his car, saying, I need help for my child and I can't get it. And both my wife and I, he and his wife are school teachers. They both have private insurance. And What they learned at the ER was that their private insurance was actually impeding their ability to get the care that their son desperately needed to get him in a psychiatric bed. The fact that the community mental health, if they were Medicaid eligible, if they didn't have private insurance, that the community mental health system would have been able to immediately find them a bed. And ultimately, that's what happened. It was the CMH system that stepped in. I received a call, I think it was on a Saturday night. I was watching a football game, and somebody from New York who had seen the video reached out to me. And I said, at the time, we didn't even know they were in the state of Michigan. And then I got a call the very next night, and we discovered that this family was in Michigan. And a mad scramble started. I started reaching out to CMHA partners and saying, hey, how do we help this family? And it was the CMHA system that was able to step in and get the family the help that they needed. But private insurance sometimes impedes because they don't provide the coverage. I mean, there are a number of reasons out there.
You know, what gets me in that story, and I remember you telling me, Kevin, about how the phone lines started, everybody was calling everybody after that video once, everybody was calling everybody, there were emails, and there was this kind of surrounding of help to get that family into the care they needed. But what
I'm sorry, go ahead, Robin.
I was going to say, I mean, part of it was the help was there, it took some maneuvering, but the help was there. But for families, it's just such a mind-boggling array of services. They don't know how to access it. If it is there, they don't know how to access it. They don't know who to call. And that's part of the problem.
Well, and most of us don't. I have to go back to my own situation. When my son Dominique was diagnosed, I quickly learned I knew nothing about mental illness, resources available, how to access them, how my insurance would benefit or not in that case. And this family found the same thing. Now, let me say this as well. The public system is not perfect. The public, again, we have a shortage of psychiatric beds in the state of Michigan. We have a shortage of behavioral health care professionals. There are a lot of needs that we need to address to make this work better. I told Robin, if you remember, we talked about a family that came to my attention several years ago. It was a young teenage son in Genesee County whose behavioral health issues caused him to be physically violent to his mother. And at the end of the day, the mom was at one point told that she would need to give up her parental rights and send her son to a treatment facility in Texas to receive the treatment that he needed. And that caused us, quite frankly, Senator Stabenow got involved and helped us find care. But to your point again, I guess I want to express the public system in Michigan is not perfect. There's room to improve. It's better than it is in many other states, quite frankly. And one of the things that I love about this system and the passionate people who work in it is, and that weekend was the perfect example. When we found out there was an issue with this family, everybody took action. I mean, my phone was ringing off the hook. I was calling people. Everybody jumped into action to say, how do we help this family? And the issue wasn't who's going to pay for it anymore. It was simply, we know there's a problem. Let's find a solution for it. And that's what happened.
And it's a good point. I need to bring up that the folks that work in the mental health system, some of them are just amazing. I mean, they go far beyond their 8-hour day, their 12-hour day, or they're getting called all night. They are doing these incredible creative maneuvers to get families help. So I don't want this to be painted as an uncaring system. That's not the case at all. And you got to remember, part of this too is law enforcement. Law enforcement pulls a lot of the help here because guess what? When your kid's in crisis, you're calling 911. If you don't know who to turn to, you're calling 911. And very often it's the law enforcement who are the first ones to respond. And they're the ones trying to sort out and plug you into care. And Tim, you can probably weigh in on this. I mean, tell us about what you found in your report.
Yeah, absolutely. Going back to your question about why, sometimes people with what they would consider great insurance have trouble finding treatment. I think, it's not a problem with the dedication and skill of the providers, like you said, but there are some structural issues that we have. And if you look historically, we made this really bad decision of thinking of mental health and physical health as these separate entities decades ago. And while, research and science have advanced and we understand how interconnected our well-being is as a human, and how, mental health disorders and physical health issues affect one another. And we have these comorbidities that occur almost universally. The treatment is not set up that way, and was not. And so even as we move toward trying to treat both mental and physical health issues in a coordinated manner, that's not the way we set the system up to work. We also have approached things really in the US across the board from a medical model that seeks to diagnose and treat conditions as they happen, which is great, and you need that. But you also need a public health approach that looks at prevention and looks at multiple levels of support. And we really don't have that with mental health. We don't have universal screenings for adverse childhood experiences and traumas. We don't have other screening devices to see when problems are happening and to intervene and to provide support, to provide either youth or adults with various coping mechanisms and other things that can make them more resilient to more serious illness. And so we're jumping in at the late stage when really serious issues are arising, and then it's a crisis response when we haven't invested any time, money, or structure in giving people the support they need throughout their lives to prevent the need for these psychiatric beds, or to prevent the need for more providers. So I think that's a big part of it as well.
Absolutely. And before you
Rob,
get to solutions, because I think that's where you're going. Oh, I'm sorry, Kevin, go ahead.
I'm sorry, forgive me for interrupting, but I wanted to add a thought to what Tim was saying. We know that early intervention is key. One of the things that we talk about often is stigma, and we at NAMI believe that stigma is the leading barrier that prevents people from seeking the help they need, from receiving the early diagnosis and treatment that leads to better outcomes. We know, and there's a lot of data to support that early intervention, first episode psychosis programs prove that if we intervene at the onset, that the opportunity for greater outcomes improves dramatically. Part of the problem is sometimes it goes unrecognized. Sometimes stigma is stigma to me is the leading barrier. I talk to young people all the time, and one of the things they tell me when we talk about stigma is, quite frankly, it's us parents that are more the perpetuators of stigma than it is the young people. Young people, and I was on a similar call with students from Plymouth Canton School District a few months ago, and what they told me was, they said, we need two things. One, we need to understand what resources are available to us in our immediate community. We don't want 800 numbers. We want to know what's available in downtown Plymouth, Canton, whatever your locale is. But the second thing was, they said, we need to know how to talk to our parents about this, because we are going to our parents and saying, hey, mom, dad, I'm not feeling quite myself. I'm having suicidal thoughts. And mom and dad are not ready to have that conversation. Sometimes it gets put off. And I don't mean to belabor it. There was a story on the Today Show a couple of months ago about a new hospital down, pediatric psychiatric hospital that Ohio State has on campus. And there was a young lady who's graduating high school this year who said she knew she had some behavioral health issues from the time she was in like the 6th or 7th grade. She said, I went to my parents numerous times and said, hey, I think I need help. And it was always pushed off till tomorrow. And she said late in her sophomore year, she went to her mom and she was experiencing suicidal thoughts. And she went to her mom and said, you need to take me to see a professional. And the mom once again kind of pushed it off and said, we'll deal with this tomorrow. And the young lady responded by saying, I may not be here tomorrow. And it was that statement that triggered her mom to take it seriously and get her the help that she needs. And long story short, she graduated from high school this year. She says she's happier and in a better place than she's ever been because she got the help that she needed. So we have to intervene early. And the other part really quickly is the issue about law enforcement. I sit on the Crisis Intervention Team International. And for people who are unfamiliar with that, it is training. It's a partnership between law enforcement and community behavioral health, or not just community, behavioral health professionals as a whole, where we teach verbal de-escalation, but also what resources are available. So we get people the help that they need, whether they're young or adult, get them the help that they need so they're not just recycling through the emergency room in the criminal justice system. That's something that we have to invest in, because law enforcement officers are trying to get it right by and large, but you're right, they're the first responders, they're overwhelmed, and they don't have all of the training and the resources that they need.
I was hearing horror stories from, and I'm sure it's all over the state, but you know, especially in the rural areas, some of these law enforcement too are responding to calls, and it takes them out for an entire shift, leaving the county or the jurisdiction basically unstaffed because they're trying to figure out what to do, how to get the family help. And especially in a rural area, if you've only got a few officers, a couple of troopers, a couple of deputies, and they're taken off the road for that crisis, you're leaving that area unstaffed. Let's shift a little bit then to solutions, because that's really where we want to take this next. There are two proposals right now. Let me back up. The bureaucracy in Michigan's mental health system, as many of us know, is just mind-bogglingly complicated. There are multiple organizations and multiple levels of care, and and trying to figure out who's going to pay for what are the best services. So there are two proposals right now, as many of you know, one by Senator Shirkey and one by Representative Whiteford. There are other proposals, of course, to fix the mental health care system, but these two have been getting a lot of traction lately. Now, both of these would take this complicated managed care system, this one layer within the system, and collapse it. Senator Shirkey's proposal would take that system or that level and push it over to Michigan's private healthcare plans. So you may have heard that's where we're talking about privatizing the system. And then Representative Whiteford's plan would also reduce that layer, but send it over to an administrative services organization. So if you read the proposal, there are lots of acronyms and whatnot in there that'll get you confused. But in essence, both of them would collapse kind of this managed care system or change it. Tim, let's start with you, because I think you can talk about why getting private health insurance might work here.
Sure. I think that my focus would be less on whether something's private or public, as opposed to what the structure is in terms of integration. And so I think what we really want to see is a continuity of care that treats people as a whole entity and meets their behavioral and physical and social and spiritual health needs, for that matter. And so, one way to do that would be to have all of the money that funds those various services in the same place. Because right now we have a lot of different providers that do things their own way. If you go and talk to them, what do you think of integrated care? That's great. But they've been saying that for decades. We haven't seen changes in practice, and really it's like herding cats, getting everyone to talk and work together with different systems. And as a cat owner, I can tell you, if you want to get the cat to go somewhere and do something, you grab the food dish and move it, and my little kitty will come right with me. And so there's a proposal in Vermont right now that would be a section 1115 waiver for their global commitment to health, and that would create a public system that would be a state-run managed care that would pay for the Medicaid population, physical and mental health, pharmacy services, substance use disorder services, long-term services and supports, all of these things in the same way. So you can really look at a patient, see what their needs are, and then care for them and make sure that they have the right set of providers needed. In Michigan, I think that's unlikely to happen. Most of the money is in physical health, and the way we've done things in Medicaid is that we moved to managed care by contracting with private insurers that already exist and using their staff. That's how we expanded Medicaid with the Healthy Michigan plan. And that's been very successful. I think no one would argue, some people would, but there have been problems, but they've been addressed by the state writing really great contracts to make sure that people have coverage. And I don't think the private label on that coverage has cost people. I think Healthy Michigan plan largely, and you can look at my research in the past on that, it's been fairly successful. So proposals that merge, our mental health funding, the way that we provide Healthy Michigan, that's one approach that could be successful. I think the real focus needs to be on integration, however.
It seems like it should be easy. Somebody who treats for a heart attack, the doctor who treats for a heart attack could call down the hallway or whatnot and talk to the person who's, or the heart problems, call down to the hallway to the mental health provider because maybe the depression or the anxiety is feeding into that. I'm making that up. I have no idea, but it seems like it'd be easier to make people talk to each other.
Sure.
But I hear what you're saying.
People with chronic diseases and cancer often develop depression and other disorders. Likewise, people who have
That's much better example.
Yeah, people who have long-term issues with depression, with anxiety, with substance use disorders, they're more likely to develop other chronic health conditions. And so really, I think in the most cynical world, you can say that the insurance companies are just in it for the money, and that's their bottom line. As a private entity, they need to turn a profit, and that's true. But if I were an insurance company looking at a patient, I would want to intervene early with their mental health issues rather than letting that explode into really costly chronic health conditions later. And so there is an incentive, even from a market lens, to make those kinds of investments to help patients.
I want to get to some reader questions because we're running out of time. But Kevin or Dr. Alavi, and like the briefest section, do you have concerns with the proposals as they stand now?
I don't know much about the politics of it, and I'm going to stay out of that. But I will say this: when we look at the existing system, a couple things. Over the last year and a half, I will tell you, because I'm part of the group of providers that continued to work throughout the pandemic, my colleagues, physicians and otherwise in the community mental health system, they worked hard. We were there, we stayed on our toes, and I'm not saying others didn't, but for once, our system was working beautifully in concert together, and we were responsive and we were proactive. What I would add is whatever system redesign or change happens, we have to make sure of two things, integration being the key here. What hamstrings, what really hampers the community mental health system is the way the funding is designed. It's designed for what we call moderate to severe mentally ill. So we don't get funded. We don't get program support. We don't get anything that says, yeah, you treat the severe, severely mentally ill, but here is this pot of money and here is this program support for you to actually prevent people from getting there. And I am very passionate about that because I'm a child psychiatrist. And let me tell you, prevention is the name of the game, but our hands are tied. We're not funded for prevention. So whatever the changes are, whoever funds them, however it's done, it needs to be integrated, and it needs to have prevention and proactive approaches built in. Otherwise, we're just going to be putting out fires once they've already started.
Talking about the need for psychiatric beds instead of the front end care, right?
Yes.
I hear you.
Yes, absolutely.
Kevin,
Thanks.
you look like you were hankering to say something.
So really quickly, I agree with both what Tim and Dr. Alavi said. Our biggest opposition specifically to Senator Shirkey's proposal is the definition of integration. Integration has to occur for it to be effective. Integration has to occur at the point of service delivery, not at the point of finance model, because when people focus on the money, that's when it all gets messed up. And whether we're concerned about private health plans turning a profit, The real issue should be, as Dr. Lavi said, prevention. We have to invest in prevention. We have to invest in intervening at the first sign of psychiatric issues. We have to make sure the public is aware of and have access to what resources and providers are available to them, because so many don't. There's so much we can do on the front end to prevent. And we talk a lot about the need for additional psychiatric beds and those things, and all that's true. But if we were not reactive, if we were proactive, as I think Dr. Alavi was suggesting, we could get ahead of those crises. We could get ahead of the need for so many psychiatric beds. So our opposition to, again, Senator Shirkey's proposals, bills 597 and 598, first has to do with where does integration begin? And then there are lots of other issues with that bill that are, quite frankly, are non-starters for most of us in the advocacy world and people who receive services. I'll leave it at that because I know I want to be sensitive to our time.
You know what, I'm just going to jump in if you can hear me. What are the equivalent of psychiatric illnesses for children? Early signs, that's the problem right there. When we're talking about a 3-year-old, you're not seeing psychiatric illness. I'm speaking as a mom of adopted children with attachment disorder that is only now being understood. So I'll stop there. But your language.
Actually, that was one of the questions that came in early. Is before we started this, one of the reader questions was, especially as we're starting school, and I know a 3-year-old obviously may not be starting school, but at what point does a parent, feel like this is normal anxiety, normal growing pains, and get professional help, or start having those conversations with the experts? And I don't know if Dr. Alavi, maybe you could talk a little bit about that.
Sure. So let me rephrase the question to make sure I understood it correctly. So this is what I heard. What are some of the signs, especially now as kids are starting to enter school, of whether this is just some distress, some adjustment issues versus something more severe, something that is more of a disorder? Is that the question?
Yes.
Okay. So in children, things can change very quickly, right? But you also want to allow room for the normal developmental ups and downs that happen. And so we don't want to overly medicalize anything and everything. But by the same token, we don't want to ignore what could be an impending episode of psychosis. And again, I think that the first stop is the pediatrician's office, right? You pick up the phone, you say, hey, I need to bring in my 4-year-old, my 2-year-old, or my 16-year-old, because they're not leaving their room, or they're doing something that they usually don't do. So that's their first stop. But then we need to have room for the primary care provider to quickly say yes or no. Yes, this is within because that's what they're trained to do. They are experts at developmental and behavioral changes in children. And so we need to have that other track where you call with a question, you take your kid in, and we should have something for them to fall back on and to say, yeah, okay, no, this doesn't make sense. Let me get you in. Either you take your kid in, or let me call somebody who can help me. I think that's one thing. But the second thing too is, medically speaking, we say something that something called adjustment disorder, which simply means that if somebody is going through a sudden change, it could be a traumatic event, or it could be a good change, but a change, and you develop a change in your moods, in your sleep, in your appetite, in your functioning, then that's more than likely, if it's in the first 30 to 90 days, it's just an adjustment, and it should resolve after that. If it doesn't resolve, then seek help. But even in that first month to 3-month period, it shouldn't get to a point where it's dangerous, right? So safety trumps everything. And if it's at any point a safety concern, please ask for help. And I say, go to your pediatricians. I mean, they are the first line. At CMH, we are in the trenches in the first line, but like I said before, we're not set up to provide that level of support. So get us more funding. So we can do it.
Absolutely. And it did, and I'm sorry, I couldn't tell quickly enough who was speaking. So I apologize, but to that person, that brings up a great point. One of the things that came up again and again as we were talking to folks back in May and June is that, especially with these really young, these real young kids, there aren't a lot of services for the most severely, the ones with the severest issues.
So that was me. That was Peggy Dolane, and I'm from Washington, but I'm on Torch Lake right now for the summer. And I want to continue to add my children attachment disorder. Like when you're in the primary care physician's office, and I agree with not over medicalizing and children's development and all of that, but still you go towards the language of an impending episode of psychosis. Part of the problem is behaviors in children develop. So like oppositional defiance disorder develops in response to a parent-child bonding. And we have not well understood how to notice and identify that and talk about that as behavioral health as opposed to things. Yes, we have serious mental illnesses that can show up in childhood, but the kids who are in jail, homeless, prostituting, not attending school, many of them are kids that have behavioral grounded, like neuroatypical that has never been screened medically because of what we've said earlier. So I'll leave it at that again. Thank you for listening.
No, thank you for the question.
Yeah, our Citizens Research Council report touches on that a bit, and I'll leave the diagnostic criteria obviously to Dr. Alavi, but when you look at the epidemiology of whether it's depressive disorders, anxiety disorders, neurodevelopmental disorders, many of these things manifest in childhood or in early adolescence. And if they're not screened for and not caught early, they do worsen into adulthood and stick with people. So that early intervention is key and prevention.
Let's take, one of the questions, and this is something that I think frustrates or, confuses a lot of people, or is certainly a giant challenge in all of these areas, in the entire spectrum of care. What we're talking about once again is a lack of people, a lack of workers. So one of the questions is, who's got some innovative ways to attract or retain mental health care professionals, specifically in rural communities, although we know this is an issue in other communities too. Can philanthropy play a part in this?
Do you mind if I jump in?
Please.
Yeah, there are a lot of different strategies that have been floated. We've looked at this with primary care physicians for a while because Michigan, as we talk about primary care physicians taking on some of this burden, there's also, there are shortages of primary care in parts of the state and a maldistribution of providers. Some programs have looked at loan forgiveness or residency training programs that locate people in rural communities to get them practicing there. That's one strategy that could be applied to all levels of providers and all types of providers, especially loan forgiveness or other incentives for study within social work, within psychology, within professional counseling, for psychiatric nurse practitioners as well. I think recruitment from rural areas is also important. Medical schools are great, universities are great, but when you look at medical schools, most of the attendees come from higher income families and tend to come from urban areas. And if you're not drawing from a diverse set of geographic and social backgrounds, it's not likely that someone who grew up in Oakland County or Ann Arbor is going to have a strong desire to move to a rural part of the state because that's not what they're familiar with. When you try to attract people from different parts of the state and have concerted recruitment efforts, then people can really go and practice their craft and their care in their own communities where they already have connections. And then I think a third part of this comes into immigration. And what we see in primary care is that a lot of immigration issues allow us to draw physicians from other countries who come to the US and practice, and they fill in a lot of the gaps of things that we really need. And so our immigration policy is certainly going to affect the way we're able to attract or not people to come and practice in Michigan. And so that's not only the written explicit policies, but also the attitudes within communities and how welcoming they are toward immigrants who may want to locate there and work.
We have to wrap up pretty quickly, but I'm wondering if somebody can take in 30 seconds an answer to one more question. So whichever the three of you can answer in 30 seconds. One of the questions is commenting on the access to mental health care for two really high-risk groups. And that's transgender and diverse kids, and those kids in foster care. Those are populations that don't often know how to access care. Can somebody answer that in 30 seconds?
I'll take a shot. Put me on the clock.
All right, 30.
First of all, stigma plays a huge role in the LGBTQ community. The other part, Robin, that you mentioned again is understanding having access. And in Michigan, as a matter of fact, across the country, Senator Stabenow and Senator Blunt out of Missouri sponsored what we now call certified community behavioral health care clinics, which take all comers. So regardless of severity of diagnoses, insurance status, or ability to pay, if you can, and Michigan has almost 30 CCBHCs now. So if you can identify a CCBHC, you can get access to care. That's just one way.
We did talk a little bit about those CCBHCs in our package. So please do check that out. And I'm going to turn this over to Amber, but thank you all for joining us. And Amber, I'm going to turn it back to you.
Thanks so much, Robin. And thank you also to Kevin, to Tim, to Dr. Alavi. This has been just a magnificent discussion, and we are so thrilled that you are willing to spend your hour chatting with us about this very important and very timely topic. I also want to thank you, Robin, and my colleague, Catherine, for making this event possible, and to all of our Bridge readers who participated today. We are so grateful that you were willing to spend your lunch with us, and I hope that you learned a lot, and we'll continue to cover this topic in Bridge. Just a reminder, we're recording today, and we'll be posting this recording in Bridge this week. So if you visit bridgemi.com, you can watch again or send the link to someone that you know who may have wanted to watch but didn't have the opportunity. We will be resuming our monthly lunch break series on September 29th. An announcement on that event will be coming soon in Bridge. That is all that I have for you right now. You can see that there's information in the chat about some of the stories that were written. And also Robin shared her contact information. So if you have questions for her, please feel free to follow up there. Thank you so much to all of you. I hope you have a wonderful day, and hopefully we'll see you at a future lunch break event. Take care. Bye-bye.
Thanks so much, everyone.
Bye-bye. Thank you.